We once again thank Dr. Al Sommer for honoring us by his acceptance of the award and delivering his life's work.
President of the Govil Trust, Finance Director and the true builder of Aravind Eye Care System, Mr. G. Srinivasan will now present the G. Venkataswamy Endowment Award for the year 2017 to Dr. Alfred Sommer. Dr. Al Sommer has certainly crossed borders and reached out to many in the world. He has fostered, mentored many across the globe. May I now invite him to deliver the oration on an ophthalmic public health journey.
Well, after that introduction, I probably shouldn't say anything because I could only disappoint you. I wish my wife were here to hear what the wonderful things Tulsi and everybody else said about me. She wouldn't believe any of it. So I'm not going to relate any facts that anybody has to remember or write down. What I'm going to try to do today is simply give you a feeling of my own personal journey in thinking about health problems, which has largely meant encountering an episode that seems not a good outcome, thinking about how one might change that. And to me, many of these things seemed absolutely obvious, but they were so obvious nobody had ever bothered to ask the questions before. So let me begin, if this would work. That's not working. Here we go. Well, we know really why we're all here today, and that's because of our fond memories of Professor Venkataswamy, who I did have the great privilege of knowing and working with, and who stayed at our home several times. The first time, he was in a room that was on the top of our house, which is an old house and is surrounded by trees. And he came down in the morning with a big smile on his face, and he said, "I didn't know America had birds," because these trees get filled with birds in the morning and they chirp away, and I don't know where he used to stay, but when he'd come to Baltimore, he'd stay with us and he would hear lots of birds in the morning. As has already been mentioned, we first became acquainted before there was ever an Aravind. We became acquainted over the issue of xerophthalmia, childhood blindness caused by vitamin A deficiency, and Dr. V was in fact a founding member of what was called the Xerophthalmia Club, which put out a bulletin periodically. Other members of that club were Don McLaren, somebody who used to come here frequently from Oxford, Tony Morrison. So we've had, that was our first thing, and there's Dr. V actually with an article, one of many that he contributed to this growing awareness about the problems of vitamin A deficiency. In 1977, early, January, February, the United States Agency for International Development decided that they should train a group of international ophthalmologists to be able to recognize xerophthalmia. And Dr. V hosted that meeting here, not in this big, beautiful facility you have now. Aravind then was the 11-bed private facility, but because, as has already been mentioned, he was interested in nutritional blindness, and it was very common in this area. These people came here in order to learn about the disease. I was living in Indonesia at the time, but Dr. V asked me to come and give the course, so that's me looking at some of the children here. I don't have too many pictures of Dr. V with wine in his hand, so I thought I would show this one. Usually it was tea, but I actually found this picture where he's got a glass of wine. I can't remember whether he drank it or he just held it. Now, he would visit me usually at least once a year when he was in the United States for other reasons, but he never told me ahead of time that he was coming to visit. And in the morning, suddenly he would appear at my office. And he would say, Al, I know you're busy, so I will just sleep on your couch in your office while you have your meetings, and in between the meetings, I'll get up and we will have our discussions. And that happened every year. And of course, as those of you who worked with him knew, he was absolutely obsessed over the idea that McDonald's could do millions of hamburgers and we couldn't do millions of cataract operations. So that led me to have our artists prepare a couple of slides for him. This was the first slide that I prepared for him, over 20 million needed as opposed to delivered, and it's got a cataract in the center. I, of course, was also taken by the tremendous efficiency with which Aravind developed its delivery services, which basically meant that everybody performed a job that they were capable, at the highest level they were capable of functioning. So you didn't have an ophthalmologist prepping an eye, you could train a technician to prep the eye. So I made this cartoon for Dr. V to show that you could make it an assembly line, efficient process, and keep going. And then, of course, we dealt with the issue of how do we get people to want cataract surgery and want it earlier in visual disability. And he came up with the observation that most people would be willing to pay about 2 months' wages towards the cost of their cataract surgery. So the idea was if we could convince people to come while they were still employed, have their cataract surgery, they would only lose 2 months' worth of wages, but they could keep working because they would be able to keep their sight. So I tried to capture that idea in this cartoon that I made for them. So you have these truck drivers with cataracts going into the Aravind eye system, and they come out with their IOLs, and they see perfectly well, and they can keep their jobs. This was the first eye camp I attended. This one actually happened to be outside of Delhi, but is for those who have never actually seen the old-fashioned eye camp, that was an eye camp. And one tent was for the surgery, and one tent was for the examination, and one tent was to put the people up. Now, Tulsi and I have been going back and forth about a job I've suggested to Tulsi, which she's a little hesitant about doing. But what is remarkable to me, and I show this slide often, is that India changed its cataract surgical rate. How many cataract operations are performed per million population per year? From 500 to 5,500 over a 30-year period. But that is a 10-fold increase. No other country has done this. And obviously, Aravind set a model to do it, but here you have a whole country that took up that model and did this. And what interests me right now is what were the various factors that caused India to dramatically increase its cataract surgical rate. I mean, China has not done this. Certainly sub-Saharan Africa has not done this. Indonesia has not done this. What was it? Now, it's true, there are unique things about India and Indian philanthropy and wanting to do good things, but this is a remarkable change to me. In fact, that's the reason I cut out this article from the Daily Telegraph. I happened to be in London 1998, and the article that there was man beats National Health Service wait by going to India for his cataract operation. So here you had people flying from London to India where they could get good cataract surgery at quite low cost. So now we go into some stories about thinking about data and research. So data are important. We collect data. We love to collect data. But they don't necessarily make any difference in the world. You have to go through a long and sometimes very tortuous series of events to go from data to policy, from data to programs. Because initially, lots of people won't believe your data because it's new, it's different, it's not what they believed before. So you have to get a scientific consensus. And even if you get a scientific consensus, it doesn't mean that that's going to change policy or clinical practice or programs, because you have politics, you have competing priorities, you have media attention, all the things that come in the way. But for me, what I tell my students and my young faculty, if you have found an insight with strong data that suggests or indicates or proves that you have to change clinical practice for the benefit of humanity, you have a moral obligation to go through this entire process to change policy, change clinical practice, and change programs. So this was my first taste of public health. This was, as Tulsi's already said, I went to the Cholera Research Laboratory in Dhaka, then East Pakistan, and was working at the Cholera Research Laboratory. And this is obviously a distressed mother with 2 children with cholera. They did fine. We treated them by keeping them well hydrated. But I was actually sent there as an epidemiologist to test new cholera vaccines, do field trials to prove whether they worked or not and how effective they were. The problem is, when I got there, we didn't have any new cholera vaccines to test, and the ones that they had were absolutely worthless. So I had to find something to do. So I posed a very simple-minded question. The cholera laboratory maintained a surveillance, household to household, of a population of about 100,000 people living in a rural area called Matlab. And anybody who developed diarrhea was taken by speedboat to our local, where we had a makeshift hospital, and treated. The person who was doing the epidemiology before I got there, who I replaced because he had already done his 3 years in the field, had collected for 3 years data on everyone who had developed cholera in this study area. And so I decided to ask what, like I usually do, a very simple question. If you used a protected water supply, would that prevent you from getting cholera? Can we advance the slide, please? So, would the use of a protected water supply reduce the risk of cholera? And I had the field workers, we already had all the data from 3 years, we knew who got cholera and who didn't. What I had the field workers do is map every one of the villages, and as you may be able to see here, when you map the villages, we also put on the map not just the houses, which are the little black boxes, but where the ponds were. And the ponds where most people got their drinking water. The X's were deep well pumps. And I just made this simple-minded assumption that people who live close to the pumps probably are more likely to use water coming from the pumps, clean water, and people who live further away are probably not, and they're probably using the pond water where people defecate, people wash their clothes, people do their swimming. And so we compared the rates of cholera that had occurred in the previous 3 years for people who lived close to the deep wells and people who live further away. And it was a very interesting and still unexplained phenomenon. The common form of cholera, the organism was called classical Inaba. And it's called classical because it's been around in the Bay of Bengal for probably thousands of years. If you had classical Inaba infected cholera, living near a tube well reduced your risk of cholera by 7-fold. So obviously, using a clean water source had a dramatic difference in what your risk of cholera would be. So that was very nice, and I was feeling good about that until I analyzed the data for a new bacterium causing cholera called Eltor ogawa that had just come into the region about 5 years earlier. And there it made absolutely no difference. The risk of getting cholera, whether you lived near a tube well or far from a tube well, was no different. So that suggests that probably there was more person-to-person communication of cholera for Eltor ogawa, whereas the classical Inaba was probably mostly transmitted through the water supplies. But we could never prove that because right after we completed the study, we had the big cyclone disaster of 1970, and then that was followed by the Bangladesh War for Independence. We were evacuated and we weren't able to do that. But it was an interesting finding where we've not yet finished. Now this is the article that I published of that finding. It took a couple of years to get the data together and get back following the war to be able to publish the article. And that got me to thinking, what was the value of what was then the common health policy for dealing with a cholera outbreak in a village, and what the almost universal strategy here in the subcontinent was, is if somebody reported there was an outbreak in a village, the central office would send a vaccination team, the vaccination team would vaccinate everybody in the village. And I was simply able to calculate that the effectiveness of the vaccine, which was only about 40%, and the duration of its effectiveness, which was only a few months, and the amount of days it took the team to be notified and to get there meant that all the money and effort of vaccinating a village was worthless. By the time the team would get to a village, everybody who was going to be infected was already infected. So this was a pure policy paper that said these activities are worthless, you're wasting your time, money, and effort, better think of better things. Now, many of you know about these yellow cards. Well, back in early 1970s, you could not go to any country in Asia or Africa without having a cholera vaccination. Now, cholera vaccine was a nasty vaccine. It hurt. It gave you a big red mark on your arm. You usually got fever, and it was absolutely worthless. So what I did in my usually innovative but simple-minded way is I made up my own cholera vaccine stamp. And so before I had to go anywhere, I would just stamp my yellow card and said that I had gotten a cholera vaccination. The only problem with this is word got out, and soon there'd be long lines of other people at my office wanting me to stamp their vaccination cards for them. I could have made some money, but I didn't. At that same time, when I was living in East Pakistan, because of the cyclone disaster, we were called upon to recommend what did the country need in health services to respond to the disaster. Actually, the ambassador was quite smart. The then Pakistan government asked for 12 field hospitals and 25 x-ray machines, and the ambassador came to us and said, do we need these things? And we said, well, we'll do a survey. We did a survey. We showed we did not need any of those things because when a cyclone thing comes in and it goes out, it's unlike an earthquake. There's nobody buried. Either you're strong and healthy and can hang on to a tree, or you're gone. So we didn't need that. But the other thing we wanted to do was to see how well nourished the population was and where would they need relief supplies. I knew nothing whatsoever about how do you measure the nutritional status of a population. So I quickly read up one book, and there were 3 common anthropometric techniques that were universally used. height for age, which is really not a good indicator of acute malnutrition, that's long-time malnutrition, weight for age, which has the unfortunate problem that you have to know somebody's age, and most people in the village really don't know precisely what their age is, and you need a very robust scale, which were not available in those days, or weight for height, and that suffers from you still need to get an accurate measure of height. So I had recently become aware from a colleague who had worked on a nutrition problem during the Biafran War in Nigeria that a Quaker relief team had come up with a new idea, which basically was measuring arm circumference. And they called it the quack stick, one because it was the Quaker upper arm circumference, but they also didn't know that it really was very good, so they made it, quack. It's not really, this might work, this might not work. Well, we used this. We went ahead and measured children's arm circumference. This was the only thing we could do in a normal part of East Pakistan, not where the cyclone was, so that we would have some percentiles. You say, well, these are the children who are the most wasted. They're in the bottom 10th percentile. The next group is in the next 40th percentile, and then you have the upper 50th percentile. So we did these percentiles, we did the survey, we gave the results to the government, and then the war broke out, we were evacuated. I'm back 18 months later because of a smallpox outbreak. And it dawned on me, we had these 5,000 children who were then normal, living in the Matlab field study area where we had surveillance, so we knew everyone who had died or moved away. I could go ahead and see how valid this arm circumference measurement was for predicting whether or not a child was going to die. So I had 3 cutoffs: lower 9th percentile, 10th to 50th, and above the upper 50th. Those are the thickest arms. And here were the results. Do I have a pointer? Maybe I have a, well, it doesn't really show up. Basically, what we're showing here, children who made up 8% of the original population, in the first month after we measured them, they accounted for half of all the deaths, and their risk of dying was 20 times the risk of all the better nourished children, as measured by this technique. And then even if you went out to a year later, the children who were dying a year later, who were in that bottom 10th percentile, was still 3 times more likely to die than were the children who had thicker arms. It turned out that nobody had ever used any of those traditional techniques to look at outcomes. So I wrote up this paper, and I thought this was very exciting as an epidemiologist, and I got back, one is unconvinced that arm circumference was reasonably predictive of death. One group dies at 20 times the other group, and that's not reasonably predictive. I don't know what is reasonably predictive. These refer only to 1 to 4-year-olds. Well, that's the highest mortality. And anyway, so it goes on, and that got rejected by that journal. This is the nicest rejection I ever received. I've received a lot of rejections, but this is the nicest one from The Lancet. I must ask you to forgive us for having decided in the end, and with great reluctance, against accepting your paper. The Lancet is most awkwardly situated. That's a very nice rejection. Well, you don't give up, so we eventually published this in the American Journal of Clinical Nutrition. Even they weren't too sure about it, so they have it under the thing International Nutrition. And then 2 years later, and I had nothing to do with this whatsoever, the World Health Organization was becoming concerned about nutritional surveillance because they wanted to be able to predict populations that might need intervention before lots of children started to die. And they had a committee come together and write this expert report. And the expert report basically said, there's only one piece of data that we have, and that's Sommer and Lowenstein, and we ought to go do that. And that's what led to what is now the universal use in the field, was doing mid-upper arm circumference measurements. That's how everybody measures the nutritional status of children in the field. So I'm an ophthalmologist, so I've got to tell you an ophthalmology story. When I came back from Indonesia, the first NIH grant I got was because every time I would be asked, or people like me would be asked by a place like India or Pakistan or Bangladesh or Burma, what should we do about our problem of blindness? We would always say, well, you have to do a survey. I mean, you have to find out how many people are blind. You have to find out what they're blind from. But in the United States, we had never done a survey. We hadn't done a survey anywhere in the United States. So here we did the first survey, and it was only in the Baltimore area, but it was a carefully chosen representative sample of half African Americans, half white, primarily because we had a clinical suspicion that African Americans were at much higher risk of open-angle glaucoma than were white. So that was the hypothetical basis for the study. Can we advance the slide, please? So this is, the bottom row is the intraocular pressure, and the vertical is the percent of people who have definite open-angle glaucoma, not previously diagnosed. And as you can see, and this will be important and of interest only to the ophthalmologists in the room, I think, that 50% of the population, whether they were white or they were black, had a pressure below 21. This is important because ophthalmologists for years said glaucoma means you have a pressure of greater than 21. And here we're showing that in a random representative population, more than half the patients have pressures less than 21. So that's a useless way to go ahead and diagnose glaucoma. And the next slide. Now, it is true that the higher your intraocular pressure, the greater your risk of glaucoma, and this is from that same survey. And you can see if your pressure is less than 15, it's very low, and if your pressure is greater than 30, it's very high. So intraocular pressure, higher pressures will increase your risk of developing glaucoma. But the problem is most people have low pressures. So if you multiply all those people with low pressures times the lower risk, you get more people than you do with high pressure. And that's shown here. So you have the relative risk as the intraocular pressure goes from less than 15 up to 35. The risk goes up. But the attributable risk, that is the number of people, in fact, is larger below 21 because there are so many more people who have low pressures. The other interesting thing is that the curves of intraocular pressure and risk of glaucoma in the population are identical in the white and black population. So this is, again, a hard demonstration that intraocular pressure may be important, but it's not the only thing that's important because African Americans get open-angle glaucoma 15 years earlier than whites do, and they have a much more aggressive course of disease. But their intraocular pressures are identical. So we have to, as we are now, paying much more attention what some of those other are. And this is a graph that simply shows that blacks get intraocular pressure, the red line, get glaucoma, the red line, earlier and much more frequently than whites do. So I'm trying to go, here we go. So this is, you've already seen this slide. I don't know where Tulsi got all those slides from, but I want copies of those slides. So I mostly he showed you this slide to show you that I was in Indonesia. I'm showing you this slide to prove that I once had hair. And so there I am examining an Indonesian child. Para, I think, will remember this. Next slide, please. So this is other than night blindness, the first clinical manifestation of xerophthalmia, which we then used to call early mild vitamin A deficiency, not anymore, but that's the way we thought of it, was this foamy material called a Bito spot. And so I go to Indonesia, I set up all these research projects, and the first one is to see every child that comes to the the largest eye hospital in Indonesia, in Bandung, see every child who comes in with any form of xerophthalmia. So beto spots is one. So this was a child that came in early. I'd never seen this before. So this is really localized ulceration, but it hasn't ulcered through because the iris is in the way. I had no idea what this was. I thought maybe there's some sort of strange tumor that was on the eye and thought that I would be biopsying it. Fortunately, we looked at the child under the slit lamp and it was clear this was a necrotic corneal ulcer. Well, how do you treat a corneal ulcer from xerophthalmia? Now, this is what Para will remember. We were part of an advisory group, expert committee, to recommend for WHO what should be the emergency treatment for a child with xerophthalmia, particularly if they have an ulcer. And this was our expert committee book, and based on old laboratory work and old clinical feelings, because nobody had actually studied this, we decided that the traditional treatment, which was an oily mixture of vitamin A injected intramuscularly, oily because vitamin A is oil soluble, and so everybody used oily soluble vitamin A injected into the arm. When one looked at the response to oily vitamin A in rat experiments, it was clear that the lump, it just sat there like a lump, and it very slowly released the vitamin A and was totally ineffective. So our recommendation, which was about 2 years before I moved to Indonesia to study the problem, was do not use oily injections, use water miscible injections. That's like homogenized milk where the oil is dispersed in water, because in the rat experiments when they dispersed the oil in water, the vitamin A was much better absorbed. So I turned to my Indonesian colleagues when this child appeared and I said, let me have a syringe with water miscible vitamin A. And they looked at me like I was stupid, which I was, because while we had made this recommendation 2 years previously, nobody had made water miscible vitamin A. It did not exist anywhere except in an occasional laboratory. So I immediately wired my friends at Hoffman-La Roche and asked them to prepare some for me, which they agreed to do, but by the time they could formulate it and test it for toxicity and get permission and a license to send it to Indonesia was 4 months. So what am I going to do with this child and all the children that came after him? I remembered when we were reviewing the literature that while an injection of oily vitamin A didn't do very much, it seemed like the rats did pretty well when you squirted when you put the oily vitamin A orally into them. So I got our capsule of oily vitamin A, sucked it up into a syringe, took off the needle and squirted it into the child's mouth. And so that was the way he presented, and this is what he looked like 2 weeks later. Totally healed corneal ulcer, and he's got a clear visual access. Well, while mouth versus the new fancy, very expensive water miscible vitamin A by injection. And this is basically the results. It's how many days at day 1, how many after the first dose, did they look like their corneas were improved? And then what about days 2 to 4, days 6 to 8? And you can see the results in the oral oily vitamin A and the intramuscular water vitamin A had exactly identical results. And interestingly, we had a very special technique for measuring serum vitamin A, so we were able to correlate the biochemical change and got exactly the same results. So here's that publication, which changed nobody's mind. It took us 10 years to convince the world that they should change from this inaccessible water miscible vitamin A injections, which nobody had anyway, to oral oily vitamin A. And that was the subsequent expert report. Can we advance it, please? And now it's by mouth is the primary recommendation. But it took 10 years to get that across. So you start with a study, you have the data, you got to get people to agree to it, and then you have to push to change policy. So along the way, I won't go into the story, I wrote a little book on the epidemiology and statistics for the ophthalmologist. Very simple, very short, so any ophthalmologist could read this book in one night and know the basic ideas. And the reason I did that, it was so that the average clinical ophthalmologist could better understand the studies they were looking at and reading about in the literature, and maybe the people who are doing the studies would learn enough to do better studies. And the reason I show you this is that just as I was heading off to Indonesia back in 1976, a predecessor, but somebody well known to Dr. V, Norval Christie, a missionary ophthalmologist working in Taxila, Pakistan, had the largest number of cataract cases anybody until that time had ever done by themselves. And he would do, maybe 1,000 cataracts or 2,000 cataracts a year. And he visited with me at Madurai Institute while I was doing my residency and said, Al, I think that I'm now giving a penicillin injection just before I do my cataract surgery, and I think that that is reducing my post-operative endophthalmitis rates dramatically. Would you help me write this up? And I said, of course I'll help you, since he did all the work. He had to look through 20,000 charts. All I had to do was look at the numbers that he sent me, and he said, well, before I did penicillin, this is the rate that I got, and after I started the penicillin, I got this 1/4 the rate of endophthalmitis. And so he sent me this data. And I remember those, you didn't have email then, so this took 3 weeks to get from Pakistan to Indonesia. And I'm looking at the data, and there's a big difference between when he started the penicillin and before he did it. But what bothered me was, well, maybe other things changed also. So I sent back a letter and I said, Norval, I would feel much better if you, instead of dividing them into 2 groups, divide them into 4 groups. The first group are those before penicillin in the 5 years. The next group are the next 5 years where you think they're also without penicillin. And then the next 5 years are the first few years after penicillin. And then, so we have 4 groups, 2 in the pre-penicillin era and 2 in the post-penicillin era. And what we got was not a sharp division between pre-penicillin and post-penicillin. What we got was a gradual decline. And that is, I can't point here, but that's to this side of the curve. And you can see it goes from an endophthalmitis rate of 5.6 to 4.5 to 2.3 to 0.8. So I write back to Norval, I say, Norval, there's something else going on here. It didn't change between the time you started penicillin. It started to change beforehand and it continued to change afterwards. You changed something else also. What was that? And he wrote me this long letter. I've looked through the charts. I didn't change anything else. So I said, well, all right. I mean, if that's it, that's it. You write up the methods and I'll analyze the data. I'll do the statistics and we'll put the paper together. He sends me his background and methods section. And the methods section says, and we routinely use chloramphenicol drops the night before. And he references someone named Allen, who had published a paper showing using chloramphenicol drops reduced postoperative endophthalmitis. Now, I knew Dr. Allen because he was my tutor at Harvard Medical School. And I remembered when he published his paper, which was long after the start of this series, so clearly what had happened was Norval was not using chloramphenicol at the beginning. He had started using it somewhere in the course of his cases, and he didn't remember when that was. So I said, this is not going to be very helpful. You're going to have to do a prospective a randomized trial with your penicillin and keep giving everybody the chloramphenicol like you've been doing, and that's this. And you know, it took a few years because it was 6,000 cases, and you can see that in the people who got they all got chloramphenicol. Those who got penicillin had only 1/3 to 1/4 the risk of postoperative endophthalmitis. So the point of this, there are 2 points. The first point is you really have to think about data and think about the setting and test it out in different ways. You can't just assume it's right. And that's that paper there, which made a fair splash at the time. The other thing is that was a different era. So Norval Christie took him 20 years to accumulate 20,000 cases. And you all know recently there was the same kind of study done at Aravind with 600,000 cases. And nobody, I'm sure, went from chart to chart. It was all up there on your phenomenal information technology system. So you're in a position and have taken advantage of the fact that you can do things today because of the way you do it, your work here, and the way that you capture that information that we could only dream about 30 years ago. So I don't know how many of you will recognize this picture. It's a picture that was given to me when I became dean of the Bloomberg School by close friends. That was in a silver frame. Does anybody want to guess who this is, or does anybody know who this is? Not sure. Helen Keller. It's Helen Keller dancing ecstatically with Martha Graham's dance troupe. Now think about this for a minute. This is a woman who is deaf and blind, and she is dancing ecstatically with Martha Graham's dance troupe. And on the silver frame, a quote from Helen Keller. Can you advance the slide, please? Life is either a daring adventure or nothing at all. Next slide. And that's Dr. V getting the Blindness Prevention Award at the American Academy of Ophthalmology. Thank you very much.